गगन हेलो.
यस सर.
हाँ यार रिकॉर्ड कर लेना.
हाँ रिकॉर्ड कर रहा हूँ.
हाँ ठीक. सर स्टार्ट कर दो सर. कर दो.
Today means I have covered most of the Harrison only, sir. Nothing else. Apart from that, first we will deal with all the causes and what are the different manifestation of neuropathies in various etiologies, sir. So there is one rule. I have made this as rule of 8 and rule of 4 for neuropathy itself, sir. Why I will summarize at the last. So basically neuropathy, some definitions we have to know, sir. First one is the length dependent, means the patient is having neuropathy starting from the periphery and slowly progressing upwards, either in the limbs, It could be sensory modality also, or could be motor modality also. This is called as length dependent. Non-length dependent is uh, uh, affection of sensory or motor modality either could be proximal and distal simultaneous, or proximal first followed by distal, or not classical of length dependent, like starting from distal then progressing length dependent. Neuronopathies, it is defined as like when the nerve cell body is affected. If the motor nerve cell body is affected, it is called as anterior horn cell disorders, and one of the most common causes motor neuron disease. If the sensory neuron is affected, that is dorsal root ganglion, it is called as ganglionopathy, or uh, dorsal root ganglionopathy also. So myelinopathy, or when it is affecting myelin sheath, so it could be at the whole of the myelin could be affected, or could be at the internode. Uh, if this is this classification, basically it's pathological. It could be axon which could be affected, or could be myelin which could be affected. And demyelinating is where there is loss of myelin. So while coming to, after knowing that a patient is having a nephropathy, we should know we should come to an we should know that the patient, we should ask 8 questions to ourselves, like after making a diagnosis of neuropathy. So actually Harrison has specified only 7. Why I have added 8 here is the symmetrical. So the symmetry also plays an important role here. So if the patient is having symmetrical or asymmetrical, if the patient is having which kind of modality, is it motor, sensory, or autonomic, or combination of those? If motor, it is proximal or distal. If sensory, which type of fibers, large fibers or small fibers? Small fibers are associated with pain and temperature, large fibers with proprioception, uh, fine touch, and vibration sense. The large fibers per se, the terminology includes both sensory and motor modality. uh, we are just talking about the sensory part here. And how it has evolved, it is acute, subacute, or chronic. uh, or if the patient is having associated upper motor neuron signs also or not. And after knowing, after asking all these questions, is it hereditary or acquired? When we should suspect hereditary? If the patient is having neuronopathy with early age of onset, usually less than a second decade, and if the patient is having symptoms will predominate over symptoms in a patient with hereditary neuropathies, and the positive family history. All this will help us to identify if the patient is having hereditary neuropathy or not. And associated findings we will study later. And the associated medical condition is very important. If the patient is already diabetic, we know that the patient is having, this has been the etiology. So after knowing the asking the 8 questions,
Gagan,
next we'll go to the patterns of the neuropathy. So
Gagan,
हाँ sir.
एक्चुअली कैन यू रिपीट वो हेरिडिटरी वाला? एक्चुअली मैं नेट थोड़ा अनस्टेबल हो गया था.
Be asking after. Okay, 1 minute sir, 1 minute. So total 8 questions would be asking ourselves with when it comes to the diagnosis of a neuropathy. After making a diagnosis of neuropathy, 8 questions should be answered. Is it symmetrical or asymmetrical? If it is motor, sensory, or autonomic? If motor, proximal or distal part is affected, or both can be affected? If sensory, which type of fibers? Large fibers that is associated with proprioception, uh, and vibration sense, and small fibers, pain and temperature sense can be affected. And how it has evolved, acutely, subacutely, or chronically? If it is associated with human findings or not? If the patient is having hereditary or acquired as the etiology. If acquired, we find usually it go into the picture when it is occurring less than second decades, and the patient is having some sensory signs. The patient will not complain of tingling, numbness, all those symptoms. Instead, the patient, when we examine, there will be absent reflexes, there will be more sensory modalities which will be affected. and there will be positive family history also within the hip, then we would be suspecting a hereditary cause, and associated medical condition will help us to diagnose which kind of an etiology it is. So after there are total 10 patterns in within the
Get
हाँ sir,
हेलो गगन
हाँ sir, हाँ sir.
स्क्रीन शेयर कर लो ना.
Screen share was okay. 1 minute sir, 1 minute. Now okay na sir? Yes, sir, now okay now?
Yes.
Okay sir. So after knowing the neuropathy, then we have to identify, classify into which kind of in pattern it is involving. So in Harrison's it has 10 pattern, but I have modified accordingly so that which will help us in means remembering those patterns. So we can classify into 8 plus 1. One is autonomic type, and 8 we can further classify into 4 symmetric type and 4 asymmetric type. Symmetric is that the patient is getting involved in the both upper limb and lower limb, or could be bilateral lower limb, or could be a bilateral upper limb also. So this is the terminology of symmetry. If the patient is having symmetrical involvement of motor, that is proximal and even distal, and along with that whole of the sensory modality is affected, even proximal and the distal part, and it can affect either of that. That patient can have upper limb also and lower limb also weakness, and whole of the sensory modalities also are affected. Then this pattern we usually see in GBS and CIDP. So patient will be having symmetric sensory motor with proximal and distal involvement. Next, symmetrical within the symmetrical involvement. Here the patient is having predominant distal sensory involvement, and this with respect to the motor, patient might have motor weakness, and it is usually distal, might be present or absent. So, and the causes for this includes CSPN, that is cryptogenic sensory polyneuropathy, or diabetes, or hereditary sensory autonomic neuropathy, or could be Charcot-Marie-Tooth disease, or could be amyloidosis, and other metabolic disorders. So these are the causes for the second pattern, which is symmetrical. Here also symmetrical distal sensory loss with or without weakness. Next variety is where there is symmetrical involvement. The patient is having distal sensory involvement, and patient is having both along with that motor involvement also is there. So patient will be having symmetrical sensory motor, and along with that upper motor neuron signs also will be present. So, and the causes include vitamin B12 deficiency, vitamin E deficiency, copper deficiency, even hereditary spastic paraplegia plus varieties, or hereditary leukodystrophies. So patient will be having symmetrical sensory motor plus upper motor neuron involvement. Next variety is where there will be only motor involvement. So it could be proximal and distal, it could be only distal, or it could be bulbar involvement. First, coming to the proximal and distal involvement, we classically see in ALS And another variety is spinal muscle atrophy. Second variety where there will be only distal involvement, and this causes include atypical Charcot-Marie-Tooth disease. We'll come to means various types of Charcot-Marie-Tooth disease later. And another type is hereditary motor neuropathy, and it is also called as distal spinal muscle atrophy. These are the causes of this variety. Means here also it is symmetrical only. Still we are dealing with symmetrical only. Next is the bulbar variety. The bulbar, when the next extensors are involved, we of it could be a sign of ALS. The involvement of respiratory muscle, even it suggests an ALS. Even if it is the bulbar muscles which are involved, even it could suggest an ALS. And if bulbar muscles are muscles are involved with no sensory involvement, you can suspect this ALS. Along with that, you can suspect bulbospinal variety of spinal muscle atrophy, or could be a bulbar presentation of BS. Coming to the asymmetrical type, patient will be having sensory loss also, and even you will be having motor loss also in the same site. And it can be further classified into two types. Like the patient will be having sensory and motor involvement either of only one nerve, and it is called as or one dermatome could be involved. This is classically seen in mononeuropathy and early stages of plexopathies and some radiculopathies. Coming to second variety where there will be sensory and motor involvement, asymmetrical sensory and motor involvement of multiple nerves will be involved. Here we saw only single nerve. Here multiple nerves will be involved. And this variety we often see in vasculitis, in CIDP, in infectious causes such as hepatitis B and E virus, Lyme's disease, HIV virus, and CMV virus. And other tumor infiltration could also lead to this kind of presentation. Tumor infiltration classically by lymphoma or leukemia. This can have like mononeuritis multiplex. And vasculitis classically we see in PAN, polyarteritis nodosa. Next, asymmetrical variety is the patient when there is involvement of both, could be proximal could be affected, could be distal could be affected, it could be upper limb or could be lower limb, or could be right side or left side. And along with that, patient might have sensory loss also. This kind of presentation we classically see in plexopathies. So the patient is having asymmetric sensory plus motor involvement, which is not uniform. Here we see in the only in the distal part. Here it is proximally also affected and distal also affected, and it could be unilateral, or it could be in the upper limb also, lower limb also. It could be unilateral also, or could be bilateral also. It could be right side or left side. And this kind of presentation we see in plexopathies. And plexopathies include like brachial plexopathies and lumbosacral plexopathy. And the core plexopathies include diabetes mellitus, carcinoma, sarcoid, amyloidosis, and hereditary neuralgic amyotrophy. This is one kind of an hereditary neuropathy. And sometimes it could be idiopathic plexopathy also. And we will deal with plexopathies later. And this pattern is where there is asymmetrical involvement, but no sensory. Sensory part is not at all affected, only motor part is affected. And if such kind of a presentation is there, if the patient is having proximal or distal, or patient is having right side or left side, usually this is asymmetrical, so bilateral involvement is unlikely. If involved also, it would be asymmetry will still be present. It can be further classified into if the patient is having UMN signs or if the patient is having no UMN signs. If the patient is having UMN signs, then we go ahead with this kind of pattern we see in motor neuron disease. If the patient is having no upper motor neuron signs at all, then we come with the diagnosis of, and it is involving only motor neuropathies. We are coming with a diagnosis, and the causes include here are multifocal motor neuronopathy and juvenile monomelic amyotrophy. And other cause is progressive muscular atrophy. And the last variety where there is only involvement of sensory, that is dorsal root ganglia is affected. And this include, and it is also called as ganglionopathy. And the causes include under this are Sjogren syndrome, vitamin B6 toxicity, even deficiency can cause this kind of presentation. HIV can involve dorsal root ganglia. Cisplatin classically involves this kind of ganglionopathy, and there may be paraneoplastic presentation. The patient can have this kind of variety. Even in variant of GBS, where will be classically sensory dorsal root ganglion will be affected. And these are the causes of ganglionopathy. To summarize, like we have an symmetrical and we have classified the what kind of the patterns are involved here. Could be symmetrical, could be asymmetrical, or could be autonomic alone. In the symmetrical, the patient might have sensory plus motor, and causes include GBS and AIDP. In the symmetrical, the patient can have only distal involvement with or without motor involvement, and classical example is diabetes mellitus. And if the patient is having sensory modality affected, which is motor, and also motor modality affected, and with human signs, with symmetry maintained, it we seen vitamin deficiencies like B12, E, and along with that patient having copper deficiency also, and adrenoleukodystrophy. And another variety where there is only motor involvement could be proximal plus distal, and we made a diagnosis of ALS. If only distal is involved, then we would be suspecting distal spinal muscle atrophy, or it could be bulbar muscles which could be affected, like neck extensors could be affected, bulbar muscles could be affected, or the respiratory muscle. Variety we had where there will be distal sensory or loss, or sensory and motor loss, and classically seen mononeuropathies. And if multiple nerves are involved, then we call that as mononeuritis multiplex. If there is distal sensory plus motor involvement with proximal involvement also and distal involvement also, which can be unilateral or bilateral, but still asymmetry will be maintained. And such kind of presentation, you would be suspecting plexopathies in them. And if the patient is having only motor asymmetrical involvement with UMN signs, then you'll think of MND. Without UMN signs, we'll think of other causes like motor, multifocal motor neuropathy, monomelic atrophy, and sensory neuropathy, as we discussed the causes of ganglionopathy. Autonomic causes, where the patient will be having typically only autonomic symptoms. So patient will be having increased heart rate, orthostatic hypotension, bowel and bladder disturbances will be there, and patient will be having increased sweating might be noted. All presentation of autonomic symptoms. And causes include here are total 7 causes are there. Could be amyloidosis also, could be diabetes also, and HIV also. And other causes include porphyria. There is variant of GBS only where autonomic involvement will be there, and it is usually less common. And drugs include vincristine, And another hereditary type, which we call it as Jerin-Sotos syndrome. It is a type of hereditary sensory autonomic neuropathy. So in this type, the patient will be having more of an autonomic neuropathy than sensory symptoms. So this we will study in the further slides. So after knowing the various pattern, will come to the causes of neuropathy. So it can be classified into hereditary and acquired. So in under hereditary, there are 8 important causes, and acquired also there are 8 important causes. In the hereditary only, further we can classify into where the patient will be having predominantly polyneuropathy will be the presentation, or other could be where the patient will be having polyneuropathy along with that extra manifestation will be there. Could be cardiac, could be some other presentations. Under hereditary, which are 4 most important are Charcot-Marie-Tooth disease, where the patient will be having classical polyneuropathy as the initial presentation, and along with that systems will be involved, but peripheral neuropathy is predominant. And the first causes include Charcot-Marie-Tooth disease. Second causes include neuropathic with susceptibility to pressure palsies. Next variant is hereditary neuralgic amyotrophy. And the next another variant is one minute, sir. One CMT. I discussed earlier, hereditary sensory autonomic neuropathy. So first we'll be discussing with the Charcot-Marie-Tooth disease. So the patient here, the patient classically will be involved. There will be involvement symmetrical with sensory plus motor involvement. Predominantly, involvement will be predominantly distal, and the patient will have motor disturbances also. The patient may have weaknesses, and it can be autosomal dominant, autosomal recessive, and X-linked also. Predominantly autosomal dominant. Only type 4 variety, type 4 of variety of CMT can have is having autosomal recessive uh, transmission, and another one is X-linked. We'll be discussing this also. So first is the CMT1, Charcot-Marie-Tooth disease 1. So here the patient classically, it is the most common type of Charcot-Marie-Tooth disease, and it is the most common type as a whole of hereditary neuropathies. So here the patient will be having demyelinating pattern. And what are the symptoms we see here? Like classical sensory, motor involvement will be there. Along with that, symmetry will be maintained. So other extra findings which we have to remember here is the patient will be having loss of atrophy of muscles of the anterior compartment of the front of leg. So this will look like an inverted champagne appearance. Patient having pes cavus, and along with that, patient will be having hammer toe. And patient usually presents with foot drop in Charcot-Marie-Tooth disease type 1. So when we do the electrodiagnostic studies, patient will be having an based on the only the conduction studies. In the nerve conduction studies, the conduction velocity will be very slow because it is demyelinating type. so the velocity will be decreased, and it is less than 30 second. This is the value which they have given in the Harrison. And when we do nerve biopsy, we classically see onion bulb. So these are the large fibers uh, uh, which are damaged and surrounding unmyelinated fibers along with the new so this will look like an onion bulb. Next type variety, it is the type 2 of Charcot-Marie-Tooth disease, and it is autosomal dominant, and usually it occurs in the later ages, usually over second decade. This variety, most clinical features are similar to one, but only differentiating features are the patient will have less common foot or spinal. Patient will be uh, the tremor or reflexia, which we usually or as a whole of Charcot-Marie-Tooth disease, which is usually less common. And the important difference is the second decade, which occurs usually after second decade. And the differentiating feature between type 1 and type 2, here it is demyelinating pattern, which we see in the nerve conduction studies. Here we see axonal pattern. So in type 2, we have to remember it occurs over second decade and the axonal variety. And the foot and spinal deformities usually will be less common. Coming to Jerin-Sotas disease. Here, classically, it is seen in children. Patient will have a poor conduction velocities on nerve conduction studies, and it is usually be less than 5 to 10 meters per second. Another important point which I forgot was about the type 1 variety was like the protein which is here particularly involved is PMP 22. So this protein is very important, and there are actually the patient will be having 3 extra copies here. So means the 1 extra copy, that is total of 3 copies of this gene will be there. So this will lead to this Charcot-Marie-Tooth disease. The significance will be further discussing later. Like here also there is involvement of PMP22 gene, where the patient will be having point mutation, and the patient can have recessively, but it is usually autosomal dominant than recessive condition. And the onset is usually in the children, and the patient will be having symmetrical sensory plus motor plus demyelinating pattern, and the patient will have proximal involvement also here. When we do CSF, the protein might be elevated with no pleocytosis. And classical nerve biopsy changes of onion bulb, which will be seen here. All these findings will be seen in this. CMT4, which is it is usually seen in the very rarely, and it is usually childhood onset. And further, there are further types of CMT4 also, which we will not be discussing. CMT1X. The clinical features in this are similar to CMT1. That is, the patient will be having classical inverted champagne appearance of the legs, and there is atrophy of the muscles here. There will be hammer toes, and the patient will be having pes cavus, and along with the patient present with foot drop. But only differentiating features are it is X-linked dominant disorder, where CMT1 was autosomal dominant. So male will be more affected, and usual presentation is here also it is around first to second decade only. But in females, it is less commonly affected, and if it is present, if it will be of milder variety. connexin gene is a protein which is helpful in helpful in the gap junction between the cells. So this protein will be affected. Coming to the treatment of Charcot-Marie-Tooth disease as a whole, so the patient will be having classically foot drop here. So we have to manage the foot drop here with modalities consultation with orthopedics. So the patient should have fitting shoes. Patient should have braces, ankle foot braces should be there. The patient might have severe foot drop also. So accordingly, surgery should be planned for the patient. And Charcot-Marie-Tooth disease, another important point is in pregnancy in females, the symptoms worsen and the reason is not known. So usually we supplements with vitamin C and sometimes steroids but has not shown much beneficial. Next variety is hereditary neuropathy with susceptible to pressure palsy. So why the importance of PNP protein 22 gene? I'll be saying here. Here it has 3 copies. The patient will be having actually 1 copy here. And the usual age of presentation is first to second decade. And here the age of presentation will be second to third decade. So there is symmetrical sensory plus motor involvement. But here it is asymmetrical sensory plus motor involvement. And the sensory involvement will be predominantly distal. And sometimes the asymmetry can also present as multiple mononeuropathy. That is mononeurotis multiplex, like of my kind of presentation. Next variety is hereditary neuralgic amyotrophy. So this variety, the patient will be having autosomal dominant. Usually patient present with recurrent brachial plexi. Plexopathy. So this is an important finding. The patient will have, along with the dysmorphic features will be there. So the patient will be having hypertelorism, epicanthic folds. Patient will be having cleft palate. Patient will have syndactyly. Patient will have micrognathia, microstomia, and patient will be having epicanthic folds. And with the patient will be having cleft palate also. Patient will have also the dysmorphic ears also will be there. These are the presentation in hereditary neuralgic amyotrophy. And another important variety is hereditary sensory. So here there are 5 types, and the important one is 1 and 3, which we should know. 1 and 3, third type, which we had already discussed, is also called as relay. So patients will be having predominantly sympathetic dysfunction. So autonomic symptoms will predominate over sensory. The type 1 variety, the patient will be having sensory symptoms over motor. The patient can have motor symptoms, but the sensory symptoms predominate and autonomic symptoms predominate over the motor.
Gagan, your voice is not clear.
My voice is not clear.
Or is it just me? बाकियों को सुन रहा है?
कम सुनाई दे रहे गगन अभी, पहले तो ठीक
हाँ,
था।
बस लास्ट जो अभी बताया वो नहीं सुना, बाकी तो सुन गया था पहले वाला, राइली डे से जब शुरू किया था।
So in the Rayleigh syndrome, the patient will classically have more of autonomic symptoms than sensory symptoms, and the function which is significantly affected is sympathetic function. So patient, the symptoms will be triggered during stress time, like physical or emotional stress. Then the patient will have this autonomic symptoms. And coming to the type 1 variety, here it is the most common type of hereditary sensory autonomic neuropathy, and the patient will have sensory symptoms, autonomic symptoms, and less commonly motor symptoms. But sensory symptoms predominates over the autonomic symptoms here. And what type of sensory symptoms the patient will be having? Uh, the patient will have absent reflexes, and along with that, sensory ataxia could be the presentation, or could be having a small fiber neuropathy also. And the along with that, patient will be having hearing loss also here. Patient will have pes cavus also here. Patient will have the reflexes will be usually absent here. So type difference between these 1 and 3, which we have to remember, is it is autosomal dominant, it is autosomal recessive. So we have studied the diagnosis is made by electrodiagnostic studies along with these complaints, and usually with sensory, with autonomic, with axonal kind of degeneration, axonal degeneration, which we see in electrodiagnostic studies, and the patient will be having positive family history, and the patient will be having early onset of so here in this type, here the sphingolipids, in the pathology, the sphingolipids accumulates in the cells. So this will lead to the accumulated sphingolipids causes cell injury. So we have to decrease the sphingolipids, and the treatment here is L-serine, which is given orally. The mechanism, actually I couldn't find it, how it will decrease the sphingolipids, and other which supportive care is necessary in this type. So in the rare hereditary types, the 4 which are very important are patient will be having DNA defective repairs. Under these 2 causes are there: ataxia telangiectasia and cocaine syndrome. And under porphyria, it could be acute intermittent porphyria, or could be hereditary porphyria, or could be variegate porphyria. If the patient might have neuropathy along with the ataxia, with hereditary like presentation, early age of onset, say usually less than 2nd decade, with positive family history, with ataxia and neuropathy, then you'll think of last class which we have discussed, spinocerebellar ataxia, vitamin E deficiency variant of spinocerebellar ataxia, and Friedreich's ataxia, A beta lipoproteinemia. All this comes under that. Another metabolic disorders where there is lipid accumulation is like Fabry disease, leukodystrophy, Refsum disease. These are the rare diseases. So to summarize, we have completed all hereditary, and under that 4 important we have studied. One is Charcot-Marie-Tooth disease. Under that there are 4 varieties: CMT1, 2, 3, and X variety. 4, it is we have not discussed much because it is occurs in the childhood only. And another variety is hereditary neurologic susceptible to pressure palsies. So this is very similar to CMT 1A variety, and the patient will be having here asymmetric involvement. Hereditary neurologic amyotrophy, we have to remember one word is brachial plexopathy, and the plexopathy will be here recurrent. And next we had studied the hereditary sensory autonomic neuropathy, and the important types which we have studied are 1 and 3. To 8 acquired causes. Under that, have made it as a mnemonic of vitamin D. So first is vascular causes, infections, toxins, autoimmune, metabolic disorders, idiopathic, nutritional and neoplastic, and lastly diabetes. Diabetes per se in neuropathy has varied manifestations, so I have made it as a separate classification. I have not included under metabolic here. Coming to the vascularity type of neuropathy, the patient here also we can under this 4 important primary causes include polyarteritis nodosa, the patient will have mononeuritis multiplex. Even the Chuck-Strauss variant of polyarteritis nodosa will also have mononeuritis multiplex, and it is mononeuritis multiplex is seen in 50 to 70% of cases here, and it is type of an ischemic neuropathy where the patient will be having vasculitis of small blood vessels within the nerves, so that will cause ischemia to the nerve and will cause axonal degeneration and cause axonal neuropathy in this type. And even rheumatoid vasculitis variant where the patient will have even same like ischemic neuropathy will be seen. Even Wegener's patient will be having URT symptoms, LRT symptoms with skin manifestation, and peripheral neuropathy, which is usually seen in 25% of cases. In sarcoidosis, the patient can have varied presentation. Important, which we have to remember, is cranial neuropathies, and typically seventh cranial nerve, which is usually affected here. And other varied presentation include polyradicular neuropathy can be the presentation in sarcoidosis. And in the secondary vasculitic neuropathy causes include viral infection. Under viral infection, important one is HIV. All this produces vasculitic neuropathy. And another important virus is hepatitis C, hepatitis B also. Hepatitis B is associated with polyarteritis nodosa, hence this will cause this kind of vasculitic neuropathy. Hepatitis C is associated with cryoglobulinemia, and even this causes vasculitis neuropathy. Even the diabetes also can cause the pathological mechanism could be the vasculitis of the small blood vessels. Even some malignancies, typically T cell lymphomas, can have a vasculitic neuropathy. The 8 causes and common infections. Here the total 8 important infections which we have to learn, and 4 viral. Bacterial, first important disease associated with neuropathy is leprosy, followed by Lyme's, followed by diphtheria, followed by treponema. So under leprosy, the patient will have 4 kind of variants. The patient will have here the patient, the leprosy is called by Mycobacterium leprae, and leprosy is the most common cause or the most common cause of peripheral neuropathy in Southeast Asia. This they have given in this point in Harrison, stating that this is the most common cause of peripheral neuropathy in Southeast Asia, Africa, and South America. But source I couldn't find why this was why they have kept the infectious cause in Southeast Asia. Under this 4 spectrum, we know that tuberculoid leprosy, borderline leprosy, and lepromatous leprosy. And another variant is pure neurotic type. So in tuberculoid, the immunity will be good. It will be in borderline, it would be unstable, can jump into tuberculoid or lepromatous. Depends on the immunity. In lepromatous, usually the immunity is usually poor. Since the immunity is good, the patient will have more painful kind of neuropathy. As we go down, as we go on this side, the patient will have a painless kind of a neuropathy. Here, there will be asymmetrical involvement. Even in borderline, there will be asymmetrical involvement. In lepromatous leprosy, there will be symmetrical involvement. Usually, it will be up unilateral or multiple nerves could be involved. Even here also multiple nerves could be involved, but it is usually bilaterally symmetrical and painless. And along with that, sensory plus motor involvement will be there. Even if involvement will be there, there will be asymmetry and painful will be there. Painful. With respect to skin lesions in tuberculosis, we know that there will be few anesthetic patches. And in lepromatous will be having patient will be having numerous non-anesthetic skin macules. And the last variant spectrum of lepromatous leprosy neuropathy is pure neurotic type. Here the usually patient present with like multiplex. Patient can like the body then converted into immunity as a whole, cell mediated immunity. The patient will have more release of cytokines, and then there will be exacerbation of both rash and neuropathy in this type, which we see in typically in type 1 neuropathy. Another variant which I have not discussed, total 5 spectrum we can see. I have the important one are these 4: tuberculoid, borderline, lepromatous, and pure neurotic. In the silent neuritis type, there the patient will be having inflammation around the nerves, but the classical symptoms might not be there. Coming to the Lyme's disease, Lyme's disease is caused by
Gagan,
bug of
Gagan, can you repeat what you said about pure neuritis? Sorry, वो बीच में कट गई थी आवाज.
okay. In pure neurotic type, ma'am, the patient will be having predominant present as mononeuritis or mononeuritis multiplex. That's it, ma'am. Rest all the other like lepromatous leprosy will have important is like if you remember this is usually painless, symmetrical, bilateral involvement with both sensory and motor involvement will be there. Rest tuberculoid also borderline also will be having painful asymmetrical involvement, unilateral sensory motor involvement. In the pure neuritic type, one word which we have to remember is it can present as mononeuritis or mononeuritis multiplex like presentation. Coming to Lyme's disease, Lyme disease is caused by Borrelia burgdorferi. So there are 3 patterns here which we have to remember. The patient can have facial neuropathy like a presentation. The patient can have the facial neuropathy is usually bilateral, and typically here also it is axonal type of electrodiagnostic studies which we see, and on nerve biopsy when we do that there will be axonal degeneration in Lyme's disease. Coming to the diphtheria neuropathy, here patient can develop neuropathy. So the patient in the initial stages will be having upper respiratory tract infection. Then followed by after, it is usually seen after 3 to 4 weeks. The patient will be having neuropathy, predominantly bulbar. Like the patient will be having complaining of decreased sensation in throat, will have dysphagia, dysarthria. Sometimes hoarseness of voice also will be seen. And after sometimes the patient having an infection of corynebacterium diphtheria, after 8 to 12 weeks, the patient will have sometimes present as like polyneuropathy also. So any polyneuropathy with background in the even early childhood, we have to ask the background history of like diphtheria, corynebacterium diphtheria. But in this type of polyneuropathy, it is usually symmetrical variant with sensory plus motor involvement. And if the patient like muscles also could be involved later, might require ventilator support also. So in this type variant also there is on diagnostic studies and involvement. For axonal very predominantly involved. So treatment is usually by giving antitoxin, but it is usually less effective. When we do like CSF protein, it is usually it will be elevated, and the rest of the treatment here it is like antitoxin. But compared to reversal with respect to neuropathy, when the patient has already developed neuropathy, Corynebacterium diphtheria can involve heart also and nerves also. But the cardiomyopathy can improve very well when we give antitoxin. Not, but it the with respect to the neuropathy, the when we give antitoxin, the outcome will is not so good. Coming to the last bacteria, that is Treponema pallidum. Could be Treponema pallidum or Cruz. It produces stapes dorsalis, like the sensory ganglionopathy like symptoms. Patient will have radiculomyelopathy as the presentation. In Treponema cruzi, the patient will have autonomic neuropathy. So this tapes dorsalis usually occur in the second or tertiary stage of syphilis. And Treponema cruzi can produce autonomic neuropathy. We have finished 4 important bacteria, and the next 4 important viruses are 3HW. So HIV, herpes group, under herpes group, herpes simplex, CMV and EBV, and hepatitis B and C, and West Nile virus. First variant is means first virus which we'll be discussing is the HIV, and the reasons for neuropathy in HIV patient could be HIV itself, be co-infection such as CMV, or could be drug toxicity, or per se it cannot be the HIV could not be the cause, and associated other condition might be there apart from HIV and its co-infection. So the neuropathic pattern, typically there are 4 important patterns which we have to remember, and the first important pattern is distal symmetric polyneuropathy, and it is the most common form of neuropathy form seen in HIV. So the patient having typically involvement of the distal sensory why it is occurred, it is unknown, but this kind of presentation in HIV patient can also be seen after treatment. But now this kind of presentation, because this kind of like pattern we usually seen when older drugs were given, like stavudin, like deoxycytidine, like these are the old drugs which we use in HIV. They can produce symmetric polyneuropathy, but it is usually painful. Like patient will be complaining of painful neuropathy or burning. Sorry, it will be next variant is patient can present with acute like GBS like presentation might be seen in HIV, or could be present as like chronic in CIDP like a presentation also could be there. So here all like it is demyelinated type here. So whenever a patient of HIV present with like GBS like presentation with symmetrical sensory plus motor involvement with proximal and distal muscles also are involved. So then first we have to rule out co-infection, and important core infection which we have to rule out is CMV. After ruling out CMV, then we can suspect HIV could be the cause. So other the patient be studying here mono HIV can present nerve involvement, like the ulnar nerve could be involved, in the lower limb peroneal nerve could be involved. So this kind of mononeuropathy could be we will see, and it is usually axonal type of degeneration. Here it was demyelinating. Here it was axonal type, and the first variety here also it was axon type of degeneration which we see. So the treatment in this kind of variety earlier discussed in this vasculitic neuropathy section also. The steroids might help in this case when the patient is having severe multiple neuropathies. And sometimes the patient can present with only involvement of dorsal root ganglion. So the dorsal posterior sensory neuronopathy can occur. So these are the four important presentations of HIV. Distal symmetric polyneuropathy, then followed by could be demyelinating pattern, could be acute or chronic uh, inflammatory demyelinating pattern, or could be have patient present like mononeuropathy, multiplex like pattern, and even the patient might have dorsal root ganglion involvement alone. This could be the various modalities which are present. Other important virus, herpes viruses include HSV, EBV, and CMV. HSV usually it causes asymmetrical weakness. Particular dermatome will be involved, and both sensory and motor modality will be involved. So the patient will be having post herpetic neuralgia, and in the dermatome there will be the which can present like brachial plexopathy and sensory ganglionopathies. Hello sir, voice is audible now sir?
हाँ गगन अब सुन रहा है but your screen is not visible.
Share screen. In CMV, we usually see like we had previously discussed, like patient presents with uh, demyelinating pattern of involvement, could be acute inflammatory demyelinating pattern like GBS like presentation, or patient could have polyradicular neuropathy. Means that is what the same thing is. Next viruses which is important is hepatitis. In hepatitis C, patient will be having cryoglobulinemia leading to, or could be due to vasculitis. The patient will have a neuropathy picture. In the type B hepatitis B, the patient will be having associated polyarteritis nodosa. So that's why the patient will be having vasculitic kind of neuropathy. And last viruses which be important is West Nile virus. It is motor neuronopathy. So predominantly the motor neurons are affected here. That is the anterior horn cells are affected here. So the patient will be having classically motor involvement alone. Coming to the next, finished toxin related. So targeted which we have to know is like metal related neuropathy. So known by the mnemonic malt, and the causes means M includes mercury, A includes arsenic, lead, and T includes thallium. Coming to in the mercury, usually it is pan sensory involvement. Even in the arsenic, also pan sensory will be involved. Predominant, and in the thallium there will be small fiber involvement than large fibers. So hence the sensor will be more affected than motor. So in all the type, it is axonal type of degeneration only. When we do nerve biopsy or electrodiagnostic studies, to summarize, patient will having like the patient will be having stated in the mercury star index and system uh, involved could be there is bit of connection problem, sir. I'm trying to do it as I'll try to complete it earlier, sir. So in the lead mercury, we see that the patient will be having CNS and peripheral nerve system involvement. And in this peripheral nerve system, the sensory involvement, there will be distal involvement, distal sensory involvement, and distal motor involvement will be seeing. Along with that, patient might have associated cranial nerve or sensory involvement also. And the patient on electrodiagnostic study, there will be predominantly axonal type of degeneration. And some patients, the best treatment is to remove the source only. Coming to second is arsenic. Arsenic, the patient, the patient will have symmetrical involvement, both sensory and motor involvement, both proximal and distal. GBS, patient presentation might mimic like GBS, and associated clinical features, patient might be having GA symptoms also. Patient will complain of abdominal pain, nausea, vomiting, and diarrhea also. Important examination findings which we have to remember is like the patient will be having increased pigmentation. Patient will be having Aldrich Mees line. These are the transverse line at the base of the fingernail. And these are the patient will be having multiple Mees line. And the investigations, on investigation patient, we would not prefer serum arsenic levels. Like patient levels could be normal also, some not elevated also. So that's why we prefer measuring the serum arsenic levels in urine, skin, which will help us to assess if the patient is having chronic exposure. And associated patient will be having anemia also. On electrodiagnostic study here also we had discussed like it is also axonal type. Coming to the thallium. Thallium is we see usually in rodenticides. So the patient who has consumed rodenticide, if he has consumed large doses like 8 to 15 milligrams per kg body weight, then the patient have this means symptoms. So the more the patient classically will have alopecia plus CNS symptoms, usually psychiatric. The patient will be having psychosis and sleep disturbances. And the predominantly sensory involvement will be burning type of pain will be there. And the patient reflexes will be absent. Since the patient here might present in the first week differently and second week differently. Like in the first week, the patient will have like rash, pigmentation, will notice hair loss, alopecia will be seen, and along with that, patient initially will have hyperreflexia, and later the patient develops hyporeflexia during the second or third week. This is about toxin which is related to the only metals. So other toxins also are there. Important one which we have to remember is like other important toxin like organophosphorus, seafood toxin, and tick poison. So have made a mnemonic of host like hexacarbons also are associated with neuropathies when they are exposed. Like occupational history is important in this kind of a neuropathy. So typically the patient will have all the three. All this will have the patient will have predominantly sensory involvement, whereas tick poisons, the patient will have more of a motor neuropathy compared to sensory neuropathy, and patient might have autonomic symptoms also. Like usually motor neuropathy predominates in the tick poisonings. So in the seafood, usually it is demyelinating type, and rest all are axonal type. When we do electrodiagnostics, what kind of a neuropathy we find it. So important in the toxins and drugs. With respect to drugs, most all the drugs, like they produce chronic or subacute pan-sensory involvement, and it is usually axonal kind of neuropathy. Only there are 4 exceptions where the patient can present with demyelinating, when the patient can present with neuronal involvement, where the patient can present with acutely, very acutely, the patient can present with this, and patient can predominantly have motor symptoms, not sensory. Only motor symptoms might be there. Which drugs we usually produce kind of motor neuropathy include dapsone, and acutely the patient might have worsening due to drug. Usually we see in oxaliplatin, which we use for carcinoma of colon and even tacrolimus. In the demyelinating type, drugs like bortezomib, tacrolimus can also produce a demyelinating pattern of neuropathy when these drugs are used. Next, other 8 important causes for the varieties like pneumonic CRIMS 4. Like the patient in celiac disease, the patient usually present with neuropathy, and along with that, predominantly the patient will have cerebellar ataxia. And the cerebellar ataxia might be the initial presentation in 10% of celiac disease cases also. In rheumatoid arthritis, the patient can have neuropathy, could have polyneuropathy, could present as radiculoneuropathy, and some mostly due to vasculitic neuropathy. Even in IBD also, the patient can have this, even mixed connective tissue disorders, SLE also. Jogren, important thing which we have to remember is dorsal root ganglion, which will be involved here. And rest sarcoidosis, we know that the patient will be having cranial neuropathy along with that peripheral neuropathies also. Cranial neuropathy predominantly 7th. So these are the important autoimmune causes. We have completed VITAM. We'll discuss later, but important like uremic, CLD, hypothyroidism, diabetes. Diabetes will be discussing separately. Uremic, CLD, like in the CLD, the patient will be having both symmetrical involvement of sensory plus motor plus where human signs will be present in CLD. This kind of a neuropathy we usually see, which we already had seen in other varieties like B12E, copper deficiencies, and even adrenoleukodystrophies. This which we had earlier discussed. Coming to idiopathic type. The patient usually here, it is the second most common, followed by diabetic neuropathy. So what happens here is the patient will be the particular cause we don't know. Like in Harrison, they have mentioned like it could be the cause of 50% of all unexplained polyneuropathy, and it is usually the diagnosis of exclusion, and the age of occurrence is around 6th to 7th decade. So what kind of neuropathy here we see here? As the name suggests, cryptogenic cause we don't know, sensory polyneuropathy, less of motor symptoms, but predominant sensory. And which type of sensory? It is length dependent. So patient will be having distal involvement, then slowly progressing. On investigations, you will find predominantly the sensory nerve action potential will be decreased, like due to involvement of the predominantly the fibers. And the treatment here in this kind of an idiopathic sensory polyneuropathy, the treatment is usually control the pain. If the patient is having pain due to small fiber involvement, patient will be having neuropathic pain. And prognosis is usually good. Like if the patient can have this good prognosis, that means the patient will not worsen. Like the progression will not happen in this kind of variety, and it will not lead to severe motor disability at all. Only the sensory modality will be affected, and we have to control the symptoms alone. Next is nutritional and diabetic. Under nutritional, there are 8 causes. 5 vitamin B types, that is B1, B3 niacin, 6 pyridoxine, 9 folic acid, 12 vitamin B12, and other includes vitamin E, copper, and when associated with gastric surgery due to nutritional deficiencies, the patient will have a neuropathy, and this is nutritional causes. And first we'll be discussing about only vitamin B12. Various etiologies we know, like the patient having pernicious anemia, vegetarian will be a vegetarian, the patient will have undergone gastrectomy, or the patient is having pancreatic insufficiency, or the patient is having bacterial overgrowth syndrome. And these are the various etiology of vitamin B12. Predominant the CNS symptoms include which we had earlier discussed. The patient here, large fibers will be affected. So sense proprioception and sensor, the vibration sense will be lost. So since this is involved, say, patient will have sensory kind of an ataxia, and the patient will have diffuse hyperreflexia, but absent ankle reflex. Exact cause I couldn't find why this phenomenon occurs in vitamin B12 deficiency. Like the patient will be having diffuse hyperreflexia with absent ankle reflex, but I'll try to find it and tell it. Sir.
I think it is the combination of spinal cord and peripheral neuropathy, no?
Yes, sir. Like UMN will be involved, sir. So
Hyper-
the patient will have distal means diffuse hyperreflexia, but only the sensory modality will be affected here. So that's why mostly the ankle reflex is absent. I am assuming that, sir, but I don't know that is the exact cause. Like
That was what we were taught matlab, every time. And this pattern is classically seen in vitamin E, this vitamin B12 copper deficiency, if I'm not wrong.
sir.
There are 4 classical examples of this pattern.
Yes, sir.
Abhi to I can remember only 3. Okay?
Okay, sir. Okay. And along with that, CNS symptoms include the patient. Some patients will have optic atrophy also, which we have to. And sometimes the patient will have abnormal somatosensory complaints also with respect to the CNS manifestation. On electrodiagnostic studies, predominantly it is an axonal type of neuropathy. Like the patient will be having anemia with macrocytosis, and sometimes will do the intrinsic factor antibodies, antiparietal cell antibodies if you are suspecting pernicious anemia. And then the treatment here, we usually start with giving B12 supplements, like IV supplements, like once per week for first month, then followed by every month. But if the patient has already developed neuropathy, there is only 50% that the patient might recover. That is unlikely the patient might recover completely. Another important causes, vitamin E, copper. I'll skip, sir. Like it's taking too much time. Like I have to cover diabetes also. Diabetes is important, but I'll give the notes of that particular topic. So under neuropathy associated with neoplasms, here also the patient will be having 4 varieties. Like the patient due to malignancy, direct invasion by the nerve itself, by the malignant nerves, it can cause the peripheral neuropathy. Or if the patient is having paraneoplastic like presentation, which we had earlier discussed, it can produce like dorsal root ganglion, which is predominantly involved. And due to malignancy, when we are treating the patient can develop, due to toxic side effects of drugs, can develop neuropathy. And another variant is like we are inducing immunosuppression, and immunosuppression leading to secondary activation of viruses that can lead to particular neuropathies. So these are the 4 mechanisms where the malignancy can produce neuropathy. And important malignancies like multiple myeloma, which we should know, like the patient can have a predominant distal sensory and motor involvement. This variant also we can see in multiple myeloma. Another variant is in Poem syndrome, which is a mandatory criteria for the diagnosis of Poem syndrome. The patient here will be having both proximal and distal, whereas in the multiple myeloma, usually presented with only distal sensory and motor loss. Here the patient will be having both proximal involvement and distal involvement with both sensory and motor involvement, which we see in the Poem syndrome. That is one important point about neuropathy associated with malignancy. Rest will be discussing diabetes with a little bit detail, since it is the most common cause of neuropathy overall, and it can present in 8 variant patterns, important variant patterns, and 5 are in the 5 are symmetrical patterns and 3 are asymmetrical patterns. So under 5 symmetrical patterns, first is distal sensory polyneuropathy. So this is the most common form. The patient will be having painful complaints. The patient will complain of and here also it is length dependent neuropathy, and the patient usually present with tingling, numbness, and paresthesia, and deep aching pain will be there. On nerve conduction studies, the patient will be having conduction velocity will be slowed down, but on nerve biopsy you can see both axonal and even demyelinating pattern type. Demyelinating pattern in diabetes because of the microscopic vasculitis which is occurring within the blood vessels of the nerves. So that is leading to the demyelinating pattern. So we have to treat only basically the neuropathic pain. The patient in the earliest stages will be complaining of symmetrical bilateral Claw-and-Stock pattern will be there, and along with that patient will be complaining of burning type of sensation. So the first line drugs which we usually give are like gabapentin or pregabalin, or even amitriptyline also can be. Second line drugs we go ahead with opiates. Third lines are like anti-epileptics, and drugs include carbamazepine, and valproate is usually used to control the neuropathic pain. And other emerging treatment like Botox is used, or transcutaneous nerve stimulation. Even this can help in controlling the neuropathic. Patient will be having abnormal sweating, abnormal like dry eye will be there. Patient will be having pupillary abnormalities. Patient might have orthostatic hypotension. Patient will, with respect to heart, will have arrhythmias also. The patient will have GI abnormalities like constipation or chronic diarrhea, or patient might be having genitourinary disturbances also. Next variant is like insulin neuritis type, but like the patient has no evidence of inflammation. Like why this occurs is because when a known diabetic comes with high HbA1c, we rapidly start treating with diabetes in order to when we aggressively control those, like the patient can present with this insulin neuritis like picture when there is fall in HbA1c by 2 points within span of 2 months. So then this kind of picture we'll see. What here it will be involving is like symmetrical distal polyneuropathy only, but the patient will also complain of pain here. 1 minute, sir. 1 minute. So 1 minute, I shall come. Next is diabetic neuropathic cachexia. Like the patient will be here in the insulin neuritis type. Like the patient will be having distal sensory motor involvement, and it is usually length dependent, like similar to this picture. But in diabetic neuropathic cachexia, it is non-length dependent. So patient can have this is usually seen in a diabetic patient when there is rapid weight loss. Then we have associated significant finding that the patient will be having weight loss and having diabetes which no treatment. And in this kind of variety, we have to control majorly the pain only. Rest, there will be spontaneous improvement. Even in insulin where neuritis type also, there will be patient will be having spontaneous improvement. Next is Burns-Garland syndrome. The patient will be having diabetic polyradiculopathy, diabetic myelopathy. All these are the various terminology of Burns-Garland syndrome. Like the patient will be having present with radiculopathy or radiculoplexopathy. It can involve lumbar predominantly than cervical or thoracic. So this lumbar plexus will be usually involved, and the patient will complain of asymmetric weakness, that is a sensory or bilaterally, or it can involve right or left side. This will be the presentation of radiculoplexopathy and in cervical, the patient most commonly patient can involve, like it can involve any third, upper third also, lower third also, even in the middle third of the brachial plexus. So the patient can have this plexopathy due to diabetes mellitus, and even this is also due to ischemic neuropathy. Like the patient is having abnormal nerve conduction because of the microvasculitis which is occurring due to diabetes, and that is leading to ischemia, that is leading to axonal degeneration. Later, sometimes we will find segmental demyelination also, because the other supporting nerve cells will not be seen. And other three asymmetrical variants we have, which we just to mention, is like mononeuropathy. Mononeuropathy multiplex also can be the presentation. And lastly, some patients might present with radiculoneuropathy, which we have discussed now, like Burns-Garland syndrome. These are the asymmetrical variants. Burns-Garland syndrome is not a symmetrical variant, which I had told here. Instead, the patient can present with CIDP-like pattern also in diabetes. So to summarize as a whole, like we have discussed 8 questions which we have to ask after diagnosing a neuropathy. 8 causes of neuropathy, 8 hereditary causes, and under that 4 important which we have discussed, like Charcot-Marie-Tooth disease, hereditary neuropathy with susceptible pressure palsies, hereditary neuralgia amyotrophy, and hereditary sensory autonomic neuropathy, and 4 other rare causes which we included DNA repair genes. When it is affected, can produce this kind of particular neuropathy, and causes include ataxia telangiectasia and the cocaine syndrome, and other porphyria also, acute intermittent porphyria, hereditary caprio porphyria, and variegated porphyria. And other rare causes include when the patient is having associated ataxia, the patient having spinocerebellar ataxia, and less lipid metabolism disorders, like the patient having neuropathy along with the metabolic disorders. So in this variant, like rare neuropathy causes, the patient will be having associated other manifestation apart from neuropathy. So that's why I've classified into other group. Next, we had discussed the 8 important acquired causes under mnemonic: vitamin D. Under vascular, it was around 8 causes, primary 4 causes, and secondary 4. Primary 5 causes and secondary 3 causes. Primary, it includes polyarteritis nodosa, like Church's variant also, and vaginous also. Patient can have, due to rheumatoid vasculitis, can have present with neuropathy and even sarcoidosis. And secondary causes we had studied like viral infection, diabetes mellitus, and HIV. Under infectious causes, we had studied 4, total 8, 4 bacterial. And under that, 4 leprosy, limes, diphtheria, and lastly this treponema. So in under leprosy, we studied 4 patterns. In diphtheria, in limes we studied 3 patterns of disease. Like diphtheria, like initially the patient having in 3 to 4 weeks, like initial in treponema pallidum. Under treponema, we studied 2 patterns. It means 2 variants. Like the patient having syphilis will produce like Tapes dorsalis. If the patient is affected with treponema cruzi, like the patient will have autonomic neuropathy. Under toxin, we had studied 8 causes and 4 important metal causes known by mnemonic malt, and 4 other causes include known by the mnemonic host, that is hexacarbon organophosphorus, and this tick neuropathy, and along with that I forgot, sir. Okay, and under autonomic there are 8 causes which we had discussed by the mnemonic CRIMS 4, that is CRIMS4, like celiac disease, rheumatoid arthritis, IBD, mixed connective tissue disorder, and under S4 like SLE, Sjogren, scleroderma, and lastly this sarcoidosis. Under metabolic, we had studied 4 causes: uremic, CLD induced, diabetes induced, and hypothyroidism induced. Under I, this was the idiopathic type, and it was the second most common cause. And lastly, the under N, we had studied both nutritional and neoplastic. Under nutritional, there are totally 8 causes, and under neoplasm, there are 4 mechanisms which can affect the nerves. And under diabetic, there are 8 patterns. 5 are symmetric, and 3 were asymmetric type. Like, sir, this includes means I have completed whole of neuropathy from Harrison, sir. Means important one. So that's why I included this word 8, so that as a whole we can group into one these pictures.
Hello Gagan.
हाँ sir.
मतलब it was an excellent यार, मतलब तो ये है कि तुमने तो सारा अच्छे से समराइज कर दिया, एंड मतलब शॉर्ट फॉर्म्स ऑब्वियसली वी विल गेट दिस, बट एक और रिक्वेस्ट था कि कैन यू, मतलब तुम ऐसे कर सकते हो क्या टेबल फॉर्म में हमें वेरियस डिफरेंसेस दे दो लोकलाइज करने के लिए, जैसे हाउ टू डिफरेंशिएट रेडिकुलोपैथी फ्रॉम प्लेक्सोपैथी, प्लेक्सोपैथी फ्रॉम पेरिफेरल न्यूरोपैथी, माइलो रेडिकुलोपैथी फ्रॉम जस्ट रेडिकुलोपैथी, है ना? एक टेबल बना के यू कैन जस्ट से ना, हमारे लिए बहुत शॉर्ट हो जाएगा वो, है ना?
ओके सर.
बाकी लार्ज फाइबर वर्सेस स्मॉल फाइबर न्यूरोपैथी हो गया, है ना? हेरिडिटरी वर्सेस एक्वायर्ड तो तुमने बता दिया, लेंथ डिपेंडेंट वर्सेस नॉन लेंथ डिपेंडेंट, है ना? तो इंपॉर्टेंट डिफरेंसेस जो न्यूरोपैथी में ही सबसे ज्यादा इंपॉर्टेंट डिफरेंसेस आते हैं, है ना?
ओके
तो
सर.
अगर 4-5 वो मैं तुम्हें मैसेज भी कर दूंगा कि कौन कौन सा डिफरेंसेस, मतलब मुझे जो पता है, बाकी लोगों को जो लगता है जो चाहिए वो तुम्हें मैसेज कर देंगे, ठीक है? तो बस
हाँ
एक
सर,
फॉर्म में बना
हाँ
के
सर।
फिर हमसे शेयर कर देना, ठीक है?
लास्ट
Thanks,
वो
Prabhan. Thanks.
ओके ओके मैम, थैंक्स।
बाकी तो इट वाज मतलब एक्सीलेंट यार, मतलब इतने अच्छे से समराइज किया तुमने। थैंक्स, थैंक्स गगन।
ओके सर, थैंक्स सर।